Medicine does not exist in a vacuum, but in a context of politics and culture. Therefore, our debates cannot merely focus on medical questions. With increasing rates of non-medical practices, such as female genital cutting in Malaysia, there is a need for a balanced and respectful discussion about these practices among medical practitioners. I am Dr. Hannah Nazri. I am the founder and director of the Malaysian Doctors for Women and Children. We are a group of Malaysian doctors who are passionate about the academic and scientific discourse of non-medical cultural practices that affect women and children, as well as health inequalities experienced by minority groups in Malaysia. And today, we are going to talk about female circumcision and FGM. What is FGM? In the 69th session of the Convention on the Elimination of All Forms of Discrimination Against Women, CEDAW, in Geneva, Malaysia was criticized by representatives from other Muslim countries for allowing female genital mutilation. And the response of Dato Dr. Sri Wan Aziza, who was the Women, Family and Community Development Minister, said that though FGM is seen as a cultural practice in Malaysia, it is not the same as the practice in Africa. So what is FGM? FGM, according to the WHO, is female genital mutilation or circumcision, which comprises of procedures that injures, removes totally or partially parts of the female genitalia for non-medical reasons. At least 200 million girls and women alive today in 31 countries have undergone FGMC. In Malaysia, it is said 99.3% of Malaysian women were circumcised. The updated 2007 WHO classified FGMC into 4 categories, and the most common type in Malaysia is type 4, where it says any other harmful procedures including needling and pricking the female genitalia for non-medical reasons. And this practice of FGM type 4 is what we know in Malaysia as female circumcision. So, is female circumcision a form of FGM? Today we have 2 speakers. We have Professor Dato Abdul Rashid Khan, Head of Department of the Public Health Medicine in the Royal College of Surgeons Island and University College Dublin Malaysian campus, and Mr. Brian Earp, the Associate Director of the Yale Hastings Program in Ethics and Health Policy at Yale University and the Hastings Center, and a Research Fellow at the Oxford Uehiro Center for Practical Ethics. Without further ado, I would like to invite Dato Abdul Rashid to present his talk and the historical perspective on FGM.
Thank you, Hannah, for the kind introduction. Now, let me see, how do I share? And okay. I'm having problem sharing it.
Okay, Dato, we can see your slide. You may want to open the PowerPoint presentation.
The problem is I can't see my slides. You can
Okay,
see
then
my
give me a sec.
How do I minimize it? Aha. Okay. Can you see the slides now?
Yes, Dato.
Okay, thank you very much. So, look at the time so that I don't exceed. So what is FGM? It is defined by the World Health Organization as no problem with the slides again. Right. So it's all procedures which involve partial or total removal of the female genital, external genitalia, or any other injury to the female genital organ for non-medical reasons, as what Hannah had mentioned earlier. Now, the problem with this definition is it is far from perfect. If it's anything but perfect, the problem is we will be discussing that hopefully today. But before we go into the historical aspects, it's good that some of you who are not aware of what the definition, the classification of FGM according to the UN is. So I'll just very quickly go. There's type 1, which is clitoridectomy, which is either complete or partial removal of the clitoris. Type 2, complete or partial removal of the clitoris with complete or partial removal of the labia minora. And type 3, you can have two types, which is removal of the clitoris, labia minora, labia majora, or another thing what is known as infibulation, where it is closing except for a small part of the vagina. Now, type 4 is the type that we will be discussing where it relates to Malaysia. This is all other harmful procedures to the female genitalia for non-medical purposes. That includes everything, as Hannah has mentioned earlier. Now, usually, whenever we mention female genital cutting, everybody thinks about, oh, it was practiced in the Islamic religion, so it's got something to do with the religion. Well, it predates Islam, and if you read historically, it is something that people claim has been started in Egypt. But then, if you go further, actually, parts of what is known now as Sudan, where people believe that that is where it is started. But again, we don't really know. But what I can say for sure is that it predates Islam. Now, unfortunately, for whatever reason now, most of the practice, a very large portion, more than 90% of the people who practice it are Muslims. And most of them are in Africa and Asia, basically Middle East and Southeast Asia. Now, in some countries, there are data which is collected, national data, whereas in others, we don't have the national data. So for like Indonesia, our neighbors have the national data on the practice. Now, how accurate is a whole different thing. But in Malaysia, we do not have the national data. Now, but from what studies have shown, we're quite certain that at least in Malaysia, more than 90% of the Malay Muslim community practice this. And why I'm saying Malay Muslim community, there's other Muslim communities as well, the Indian Muslim communities and the other migrant Muslim communities. We don't have data on them because no studies have ever been done on them. This data is actually based on literally a handful of studies. I think there's about 4 or 5 studies. So very little is known about what is being practiced, how it's being practiced. Although the studies that we have done are quite comprehensive, and we know what exactly this sample is doing. But again, emphasize is the Malay Muslim community. Now, to understand, because it is related to religion, we must first understand about the introduction of religion into this region. It of course started with the arrival of Hinduism. It's probably even before the 1st century of the Common Era, followed by Buddhism, and then Islam, which is in the 11th century. But here it's interesting. Usually what happens is when the kings convert, the whole population of that area will convert as well. So we had quite a number of kings in this region at that time. We still do, but the numbers are obviously much smaller because kings in those days would have been just smaller portions of or regions where they would be, so-called kings. Now, although in the 11th century, Islam was introduced by traders into this region, but we believe that it only became popular much later among the community, probably about 1300, 1400 in the Common Era. And we also need to understand about, when we talk about the Islam, the Muslims in Malaysia, the majority of the Muslims in Malaysia are the Sunni sect, and they follow the Shafi'i. Now, we have two major sects in Islam. One are the Sunnis and the other the Shiites. Now, I'm only going to concentrate on the Sunnis because, as I said, in Malaysia, basically, biggest population is the Sunni. And the Sunni have got 4 schools of jurisprudence. And the oldest is Hanafi, then Maliki, and then Shafi'i, then Hanbali. But in Malaysia, Malay Muslim population, the very large portion of them are Shafi'i Muslims. So we know that the Muslims in Malaysia are of the Sunni sect, and they follow the Shafi'i school of thought. Now, why this is important is because the 4 schools of jurisprudence, not all 4 consider the practice as mandatory for women. We're going to talk about women today, the female genital cutting and women. So I'm just going to concentrate on that. Whereas Hanbali, Maliki, and Hanafi, well, they consider, some of them consider it recommended, others do not even consider it as a sunnah. But the Shafi'i, they consider it as mandatory. So the Malay Muslim community in Malaysia who follow the Shafi'i school of thought, so they consider it as mandatory. Now, if you look at this map, it gives you an idea where majority of these 4 followers are. And we're going to concentrate on Shafi'i. As you see, a big portion of Southeast Asia, they follow Shafi'i, and then parts of Eastern Africa and Yemen and parts of Egypt. These are where it concerns us, to what I'm going to be talking about slightly later. Now, we know that they definitely did not come in as missionaries to propagate Islam, but what they did was the traders actually started coming in, following the trade routes, and they were the ones who were practicing, who were not practicing, who were doing a bit of part-time missionary work before, full missionaries started coming in and started converting people in masses. Now, we have to look at the trade route to understand this. And if you look at this, you'll understand that the parts where, again, remember, only the Shafi'i areas, which was in East Africa, parts of Yemen, and parts of Egypt, these were the people who were trading. Now, if you look at the map, you'll see that they first would stop in South India, in parts of what is today known as Kerala. And then from there, they would come up to north of Peninsular Malaysia, which is where I'm from, Kedah, and at that time also Kandram. So that was actually the first sultanate to be converted to Islam about in the year 1000 CE. However, as I said earlier, the population did not convert at the same time in mass. What happened was, it was this very gradual process over a period of 100 or 200 years. Now, another interesting thing is this, because when I saw, initially I did not understand how did the practice change, because we know that these places where we have this map, what people were practicing was type 2 and maybe type 3 and probably in East Africa. So how did it come to what we are practicing what is known as type 4 in Peninsular Malaysia. So I was just looking around and then looking at this map, and then what we did was, me and my colleague, we followed up what was happening in South India. We had some help from people from India who got us in touch with people in South India. And they were practicing type 1, which was partial removal of the clitoris. So I find it fascinating how from type 3, type 2, it came to type 1, and then from India, when Islam was propagated to Malaysia, it then became type 4. So what happened is basically it's an evolution. It's an evolution of the practice. And, the idea was to convert people, as many as possible. And in the 5 tenets of Islam, definitely female genital cutting is not mentioned. So how did people want to convert? I mean, if you're going to go in a locality and you tell them, they'll be very interested in a religion, but the moment you tell them, listen, I'm going to cut off part of a genitalia, and that definitely is going to be a turn off. So I guess it evolved from a more serious form to a milder form when it went to India, and from India that milder form became even milder when it reached Southeast Asia. This is what I hypothesize. And I've spoken to a few historians, and they say it makes a lot of sense, though. You'll see that when I do a bit more research later on. So the community here have been practicing this type 4 from the time Islam started in Peninsular Malaysia. So we're talking about a few hundred years. So we went back to the community and we asked them about what did they think about FGC, and a very, very large majority thinks that it is compulsory in Islam, meaning that if you don't do it, you're not a Muslim. Now, but this differs in the sense that I have to add on this, although this lecture is not about what they think and what they practice, but I have to add on to say that although that is what they believe, but nobody actually checks, nobody actually asks. It is not something that is compulsory before you get married, that somebody's going to ask you, are you circumcised or not? Have you done your cutting? Was it done? And, so because of that, it is not much spoken about, as it is from what I read in other parts of the world where this practice is being done. But what is interesting is that almost everyone thinks that this practice should continue. So because everybody thinks it is mandatory and that if you don't do it, you're not a Muslim. So I think I will just very quickly tell you about Islam and what other beliefs. Well, we believe in the Quran, which is the book which was revealed to the Prophet Muhammad. So if it's in the Quran, that's it. There's no discussion about it. But there's another source of information that we believe in, and that's the Hadith. And the Hadith is a report. It's a report of the Sunnah, which is, what the Prophet used to teach, preach, act, all his actions and his words, which were not in the Quran. So although it is not in the Quran at all, but they are mentioned in the Hadith, which is compiled by two major compilers, Al-Bukhari and Sahih Muslim, although there are others as well, but these are the two major ones. So what is the beliefs of the Muslims in Malaysia based that it is mandatory in Islam? It's not based in the Quran, but it's rather based on the Hadith. But then how is Hadith compiled? Well, the Hadith was compiled about 200 years after the Prophet passed away. And what they did was they based it on what is known as asnad, or the chain of corroboration. and how reliable the person who transmitted this hadith. So based on that, it can be based on Sahih, Hasan, Daif, that is authentic, good, and weak. Now, there is some controversy concerning the hadith in relation to the female genital cutting, because although only one of the four schools of jurisprudence think that it is compulsory, the others do not think it is compulsory, is because from studies have shown that most of these hadith are daif, that is, they are weak. Now, what exactly is being done in Malaysia? Well, for hundreds of years, this practice has been done by the what we call the mak bidan. These are traditional midwives before the time when there were medical doctors here. And these were the traditional midwives who used to deliver children prenatal, postnatal, you know, the whole maternity aspects of healthcare was taken care by these traditional midwives. So in the earlier, they used to have sharp bamboos and prick just the hood of the clitoris. There was hardly any cutting, it was just prick. And then, of course, they started using scissors, knives, and so on and so forth. But again, it was only a very small prick. But for what reason, I don't know, it has to have a drop of blood. No one has been able to tell me why, but it has to have a drop of blood. So if there is a drop of blood, and that's it. So I've seen many practices of the sort, and where they just put a piece of cotton and the child is running around, and that's it. Now, what is interesting is that when I first started, I could see some of the equipments which were not very clean, but when we did a few years ago, we repeated the study and we saw that now what they're using is disposable shaving blades. They will break the shaving blades, use the sharp end, poke, or slight nick, and that's it. And they would actually clean the area using some form of antiseptic. In most cases, they actually received those antiseptics from nurses. So they would just clean it and they would just prick on it, and that's it. But then, as Malaysia progressed, nobody wanted to become midwives anymore. So the number of midwives in this country has dropped tremendously. So there are very few that are left. And what is happening is people are beginning to go to clinics to get this practice done. Half of the people, the midwives that we introduced, actually were not practicing, and a lot of them had cataracts, and you know they couldn't move about. So they said that we don't practice anymore. The last they practiced was maybe 10 or 20 years ago. So what we found out that most of these people, the community, the younger ones wanted the practice to continue, but they wanted it done in a clinic, whereas the older ones, most of the practice was done on them by the traditional midwives. So now there's another evolution from traditional midwives to doctors. So this is what we call medicalization. So it is any female genital cutting which is performed by any healthcare personnel, be it nurse or medical assistant or a doctor or a specialist for that matter. Now, from the only study that we did, we found out that about 20% of the population actually practice. Interestingly, this is much less than what is reported in Egypt, but then the actual information that we have is that in Egypt it is actually much more. Here, I think it is relatively a good, reliable data, is because they don't have any fear, because the practice of FGC is not illegal in the country. So, you know, So what is it? Another thing that was interesting is that slightly more than half of those who practice FGC, they claim to have received treatment, to have received training on this, whereas the other half have not. So they just have an idea of what it should be done and they're going with it. And the other thing that's interesting is that why clinics are preferred is because of cleanliness, it's fair. And the other thing is experience and expertise. This is where it's a bit controversial because most of the doctors who actually learned how to do this, they learned it from the bidan or the traditional midwives or their seniors. And when we interviewed the seniors who had taught them, they themselves had either Googled it or they had asked another traditional midwife how to do it. So basically the training has been done by the traditional midwives. So what are they doing? Well, they're doing the same thing. They prick the prepuce or nick the prepuce, you know. So it's majority of them are doing that. The only difference is that the instruments that they're using is medical equipment which have been properly sterilized. A large portion of them actually use scissors, and they will sterilize scissors or needles. They will prick the needle and then throw away with disposable needles. But again, they all had the same thing again. They all believe that there should be a drop of blood. Now here I'm not surprised because again, you know, where they had their source of training was the traditional midwives. But what got me a bit worried, which was what I always suspected, because whenever I used to present on female genital cutting, a lot of social scientists would remind me and say, your practice is so minimal, why would you want to stop it? Well, the reason why I want to stop it is because it's now becoming medicalized. And true enough, when we interviewed some of the doctors, they were actually now cutting part of the clitoris. So it's gone into a cycle now. So what was from type 3 and 2, type 1 in India, and then type 4 in Malaysia, and now we're going from type 4 to type 1. Now, this is an issue. This is an issue. Although there were not many of them. Actually, we only found this out when we were doing the qualitative interviews, and there were about 3 out of the 24 that we're doing. But this is a start which is worrying, because when I did speak to the doctors, what their concern was, they said that it didn't make sense, you know, if you're just going to nick it, what does it do? It doesn't do anything. So that if the idea is to reduce the libido, then you have to cut the part of the clitoris. So this so-called logic that's coming in, and I feel that, you know, this might lead into something more serious if it is not stopped. What is the Malaysian Medical Council stand on it? Well, they don't have a stand on it. Nobody wants to speak about it. The whole idea that if we don't talk about it, maybe it'll just go away. Well, that's the problem. Well, I keep saying female genital cutting, and I don't think I use the term female genital mutilation. Well, there's so many other terms. In Malaysia, we use a lot of doctors, they don't call even cutting, they say it's female circumcision. I don't think that's right. We're not going around anything. It's not male circumcision. So definitely that is a wrong term to use. I don't like the idea of using the term surgeries, operation, alteration. I think it just gives validation to the practice, and the practice which has got no medical basis, a practice which we are not medically trained for this. So I'm against using that term as well. So in the villages, they use the term sunat, which is an Arabic term which means sunnah. Sunnah means that it is a recommended practice. But unfortunately, the recommended practice is now a mandatory practice among what the people believe. But again, I would like to remind you that, you know, there was an interview with this gentleman, and we had quite a number of interviews, including focus group discussions, and he said that, listen, nobody knows if you've done it or not. I've never asked my wife if she's done it or not. You know, she would probably scream at me if I would. You know, I said, nobody knows. So that is the difference from what I read, what's happening in Africa and here, is that nobody actually, I mean, it's just taken for granted that, well, you got to do it, but nobody checks. It doesn't affect your social status in your community. It doesn't affect you being marriageable or you being ostracized by your community. So it's very different than from what I read, what's happening in Africa. I keep saying from what I read because I'm not going to speak on something that I know nothing about. So what about female genital mutilation? Well, if what is being done is type 4, I'm sorry, but it's not mutilation. I'm not an Englishman. English is not my first language, but there is no maiming involved. There is no permanent damage. There is no disfigurement. So I really have this problem about this terminology, female genital mutilation. It's definitely not mutilation in any sense of the word. I think Brian will speak a lot more on that and tell you about the definition. The idea, I understand, was to make it sound as horrible as possible, to stigmatize people who practice it. I don't know who, in which universe, by insulting a person's community's beliefs and practices, would achieve a successful process where you're able to turn things around. I've really got no clues. So why do I not call it mutilation? Because the same reason when I practice, tobacco cessation, and we know for a fact that secondhand smoke is more harmful and is proven with so many scientific papers. Yet we don't go in the house and call those parents who smoke in the house where the children are there. We don't call them child abusers. So the same reason I will not call this female genital mutilation. The same reason when I work with trans people who are sex workers, I don't call them prostitutes. I call them sex workers. We have this terminology which we find fitting for a community and not fitting for other aspects of it. I find it very funny. I don't know why people think that by insulting and humiliating people's beliefs that things will change. It doesn't work. Why I'm against this terminology is because I work with the community and I respect the community, and I really want the community to understand and make decisions, informed decisions. And they would not listen to me if I go in and start insulting their beliefs, would I? Nobody would. Even I would be defensive. It's ridiculous. I'll give you examples. I got a phone call. Somebody emailed me and said they want to speak to me. It's an NGO from the US. And she called me and she had a few choice words, which I cannot repeat here. And she was so upset and she was very angry. And what a wonderful woman, actually. She made my day. It was a boring day at the office and it was amazing. And we had a good chat. Later, although I explained to her and she understood, but she said, yeah, but I still don't agree with you. And then I have the other end who think that, I should not be talking about this. And my colleagues who for some reason, think that, what I'm behaving is to appease the Western. And again, when I try and talk to them, they get upset as well. So we have two ends of this group of people who are not happy with what's happening. But this is where health promotion education is extremely important. We have to empower people. We need to educate people. We need to let them know, give them the facts. And I believe that people will make the right decisions. Okay, I think I've just reached my 30-minute point, so I will stop sharing now. Stop sharing. Right.
Thank you, Dato, for a very insightful presentation. I would like to remind everyone, if you have any questions, please put your question in the questions panel, and we will go through your questions at the end of the second talk. So I'd like to present our second speaker, Mr. Brian Earp, who will be talking a bit more about the terminology of FGM and the ethics and law behind it as well. Mr. Brian Earp.
Okay, thank you. So can everybody see the presentation? Is it visible?
Yep, it's visible.
Okay, great. So I'm going to be talking about genital cutting practices and how we conceive of them. Why would we describe a practice as mutilation when others might see the very same act as an enhancement? And who gets to determine what a practice is called and what's ethically at stake in these labeling practices? That's going to be the focus of my talk today. So the typical starting point in these discussions is always the World Health Organization, which has sort of positioned itself as the authority on this topic. And so this is their definition, which I won't go over because it was mentioned in the last talk. But there are a number of problems with this definition, which are well known, and I'll only be able to cover some of them. One of them is that the definition defines mutilation in terms of the reasons for which the cutting is done, rather than, for example, the effects on the body or the perception or interpretation of the affected person. So I want to explain why that's important. Imagine that somebody is undergoing a genital surgery that on any view is for medical reasons. Let's say it's to remove a small amount of malignant tissue on the labia or something like that. But suppose it's a botched surgery. It goes very poorly. There's extensive scarring, there's disfigurement, there's functional difficulties. And suppose the person says, well, I feel mutilated by this botched surgery. Well, according to the WHO definition, because it was done for medical reasons, it shouldn't necessarily count as an instance of mutilation. So something seems a little bit off already. And perception here is important because the word mutilation, as was just alluded to in English, it denotes a negative or unwanted change to the body. So you can see that because when people volunteer for a surgery for what they take to be cosmetic reasons, we don't refer to those bodily changes as mutilations. So we don't say nose mutilation when somebody seeks out a rhinoplasty, for example. We don't say breast mutilation when somebody seeks out a breast augmentation. So clearly there's a value judgment involved in calling something a mutilation. And the question here is, well, whose values? Is it cultural insiders who maybe have a positive attitude toward a given practice? Is it cultural outsiders who may think of the very same practice as a human rights violation? Even within the culture, is it the majority who support the practice? Well, what about local dissenters, those whose voices are often excluded from these conversations, who may want to change the practice within their own community? Do their values get to determine which language we should use? Another problem with the definition is that it assumes there's only one legitimate reason for female genital cutting, regardless of consent. And consent will be important, I'll come back to it, but this is part of the sort of medical lens, which suggests that if something's done for medical reasons, then it's legitimate, whereas all other reasons are illegitimate. Social reasons are illegitimate, aesthetic reasons are illegitimate, religious reasons are illegitimate. Well, who decides what's a legitimate reason? And how should these reasons weigh against each other? Even if we agree that it should be done for medical reasons, what counts as a medical reason? Who decides? Is it the World Health Organization that gets to decide for everyone? What about local practitioners and indigenous medicine? There's different concepts of medicine in different places. So which concept should trump? If the cutting is done by a health professional, as it's often done in Malaysia, does that make it a medical procedure because it's been medicalized? Are we only thinking of, stereotypical Western medicine as something that determines whether it counts as a medical reason? What if it's done for mental health? In many cultures that practice male or female genital cutting, the idea is that it's meant to improve the body. The thought is it makes the body more acceptable to sexual partners, for example, or it's thought that it will help the individual integrate with their community or feel identified with their ancestry. And the thought then is that that might improve their mental health. Well, mental health is a part of medicine. So can you cite some of these benefits as a reason for why it's done for medical reasons? Well, suppose active genital cutting is done for clearly cultural or religious reasons, but the family or the provider knows that those folks over the WHO seem to be impressed by medical reasons. Well, what if they add some medical reasons to the mix and say, oh, well, it's mostly for cultural reasons, but also, there's some health and hygiene reasons for why we're doing it as well. Is now it's no longer mutilation because you added some medical reasons? What if you can find some legitimate health benefits? What if female circumcision lowers the risk of infection in the excised tissue? Well, is it not a mutilation anymore because you found some health benefits according to this particular view? I think the upshot here is that you can't get inside people's heads and determine what the reason is for genital cutting. As the professor just described, there's historical reasons that change over time. There's conscious and unconscious reasons. There's reasons that you give when you're telling other people why you do it publicly. There's reasons you may give to your family. You shouldn't define if something's a mutilation based on boiling it down to what you take to be the reason for doing it. I think the relevant ethical concept is the practice medically necessary? And so I'll just give you a definition that comes from a recent paper by myself and colleagues where we say an intervention to alter a bodily state is medically necessary when the bodily state poses a serious time-sensitive threat to the person's well-being due to a functional impairment in an associated somatic process, and the intervention, as performed immediately, is the least harmful feasible means of changing the bodily state to one that alleviates the threat. So this is the concept that matters here, that we should be thinking about, but for some reason, medical reasons is the term that's been adopted by the World Health Organization. Now, another absence from the definition is any mention of consent. And this has some very strange implications. So let me spell out those implications. One is that it implies that adult, consensual, Western-style elective or so-called cosmetic genital surgery, for example, labiaplasty, which is increasingly performed on teenage girls in the United Kingdom and the United States, that should count as mutilation on this view, which the World Health Organization doesn't seem to think because it hasn't expressed any interest in eliminating this Western practice, which is done for non-medical reasons. In fact, the World Health Organization exclusively focuses on what could be called non-Western female forms of genital cutting, which should already raise some red flags. So what's obvious is that the mere cutting or removal of healthy genital tissue, which describes labiaplasty, for non-medical reasons, which describes it when it's done for cosmetic reasons, is clearly not sufficient to ground the WHO's claim that non-Western forms of FGC are morally wrong, human rights violations, torture, and so forth. So here's one way you might adapt the definition. I think this is more promising. What if you say it's the non-consensual cutting or removal of healthy genital tissue for non-medical reasons? If you don't know that the person wants this to happen to their body, if you don't know what their perspective is on it, maybe it's the coercive nature of it that should allow us to call it an act of mutilation. Well, I think that's promising, but then that would mean that non-consensual ritual male circumcision would be a human rights violation because it's the non-consensual cutting or removal of healthy genital tissue for non-medical reasons. But the World Health Organization isn't interested in eliminating this practice, which is also familiar to Western culture and happens to be a predominant birth custom in the United States, which has an outsized influence on the World Health Organization. Now, the World Health Organization tries to justify this seeming double standard by citing health benefits for male circumcision, which it derives from studies of adult, voluntary, medicalized circumcision, and then sort of just assumes that that also applies to non-consensual childhood ritual male circumcision, and there's no evidence of that. But let's go ahead and take the premise. Let's suppose that what they really mean by mutilation is the non-consensual cutting or removal of healthy genital tissue that has not been statistically associated with potential health benefits in adults. Maybe that's what they mean. Okay, well, I've just done a paper on this, which you can look into if you want to see the arguments here in more detail. But let's go ahead and consider the health benefits argument. I'll tell you a story. In 2019, I was at an international experts meeting on FGMC, and one of the other presenters asked a question of the World Health Organization representative who happened to be there. And my colleague said, given that virtually every society that practices ritual female genital cutting also practices ritual male genital cutting, typically in a parallel rite of passage that serves analogous social functions, isn't the World Health Organization sending mixed messages about human rights to practicing communities? For example, they seem to be saying both of the following. All ritual forms of female genital cutting, no matter how minor and irrespective of consent, are unambiguous human rights violations that must be eliminated from society and must under no circumstances be medicalized, even as a harm reduction measure. Well, at the same time, ritual male genital cutting of non-consenting minors within the very same communities is not a human rights violation, no matter how severely it's done and no matter how unhygienic, and it should not only be medicalized, but in fact expanded to groups that don't currently practice it. Well, the WHO official replied, male genital cutting has health benefits, FGM has none. So that was supposed to be the knockdown argument. Well, The following thought occurred to me. I didn't have a chance to ask it of the official, but I said, okay, so if medically unnecessary female genital cutting did have some health benefits, are you saying that the WHO would suddenly change its mind and concede that it's now okay to cut and remove healthy genital tissue from non-consenting girls? I imagine the answer would be no, which means that this justification is illegitimate. Now, let's go ahead and look at it anyway. The World Health Organization primarily refers to studies concerning a reduced risk in the transmission of HIV in areas with low rates of male circumcision and an epidemic of heterosexually transmitted HIV, which doesn't apply to the United States, the United Kingdom, or where have you. These HIV data come from studies of adult voluntary circumcision, not the non-voluntary circumcision of minors, so an extrapolation is being made that hasn't been scientifically validated. The reported protection is only for men from the female to male condition under ideal clinical settings. The real world data are conflicting because there's behavior change issues that you can't account for when you do this in the real world. And the one trial that looked at male to female transmission showed an increased risk to women for HIV if their male partners were circumcised at about the same rate, 60% relative risk increase. And so they had to stop the trial early for futility, and then they just don't cite this trial anymore. And the idea is that maybe women will be indirectly protected if it works for men. The problem here is that if you tell men that they have some sort of protection from having a surgery, then they think to themselves, well, I don't have to wear condoms anymore. Otherwise, why would I get a surgery? Well, that obviously increases your risk of transmitting HIV to your vulnerable female partners or male partners, as the case may be. Obviously, if you wear condoms consistently or you're faithful to an HIV negative partner, there's no benefit of circumcision in addition to the benefit that's gained from condoms and being faithful. Nevertheless, you might say on ethical grounds, if an adult wants to use genital surgery for prophylaxis while still having to maintain all the other safe sex practices to avoid increasing risk, in addition to which there's no remaining benefit of the surgery, that might be their choice if you assume that there's no coercion. Unfortunately, the way that this program is rolling out in Africa is highly coercive. And because men aren't volunteering at the level that is required by the WHO quotas, they're now targeting younger and younger boys who are 15, 14, 13, 12, 11, some of them being rounded up from school and circumcised without even parental awareness, the local officials trying to meet their quotas. So there's a real big concern about this. But anyway, children are not at risk of STIs unless they're molested. So you might think you should wait until they decide whether this is something they want to undertake when they're able to consent. Okay, against that view, maybe there are some health benefits in childhood that we should think about, and that would justify the distinction between male and female genital cutting. So let's look at that argument. The main potentially meaningful health benefit that's been cited for non-consensual male circumcision is a potential reduction in the risk of a urinary tract infection. According to the American Academy of Pediatrics, it would take about 100 male circumcisions to prevent one likely treatable urinary tract infection. Now, girls are about 4 to 8 times more likely than boys to get a UTI before the age of 5, but of course, surgery isn't recommended as a way to try to prevent these infections. Rather, they're treated. But let's just imagine that you could do this. Suppose that removing healthy tissue from an infant's vulva, so maybe trimming the labia to avoid cutting the clitoris, let's imagine that that similarly reduced the risk of a urinary tract infection. So 100 infant labiaplasties are needed to prevent one likely treatable urinary tract infection. Would the WHO say that girls do not have a right to bodily integrity, according to which such cutting would morally wrong them? I think the answer is no. They would say healthy, nerve-laden genital tissue is valuable in its own right, and so removing it or risking damage to it without urgent medical need is itself a harm. They would insist that all more conservative means of addressing potential infection should be exhausted before surgery is employed, because surgery always carries risk, even if you don't intend to remove tissue in the case of pricking. Girls have an inviolable moral right, they would say, against any medically unnecessary interference with their private sexual anatomy to which they themselves do not consent when they're sufficiently mature. So the implication of all this is that the health benefits argument is a red herring, and it's not clear whether it's really sincere because it falls apart as soon as you look at it. Again, all you have to ask is, if FGM did have health benefits that are comparable to those that have been attributed to male circumcision, would it suddenly become permissible if it's done to a non-consenting girl? Well, unless the health benefits were central to her well-being and could not be achieved in any less harmful way or by waiting for her consent, the answer is obviously no. In fact, the WHO opposes medicalization of female genital cutting, even as a harm reduction measure. Even a ritual nick performed by a trained physician with a sterile instrument and pain control is considered a rights violation by the WHO. So it seems that the WHO believes that girls have a human right to bodily integrity that's violated by all medically unnecessary genital cutting, no matter how superficial, whether or not evidence of health benefits could be found. But if this is a human right, then it must apply to all humans, including males and children with intersex traits or differences of sex development. But the WHO has no interest in protecting these children from genital cutting. Well, that's a very interesting question, why? And a colleague, Charlie Carpenter, has done some sociological work of the human rights gatekeepers who work at the World Health Organization and the UN and so forth. And what she's found is that non-consensual male genital cutting for cultural or religious reasons is prevalent within the families and the communities of the Western human rights gatekeepers who decide what counts as a violation. She writes, unlike many other practices human rights professionals condemn but do not participate in, the practice of male circumcision is widespread in their own personal social networks. Confronting this fact evoked defensiveness from those who had circumcised their own sons for non-medical reasons and were loath to think of themselves as human rights abusers. So it seems that Africans and Middle Easterners and Southeast Asians who circumcise both their sons and their daughters, and often they circumcise their daughters less invasively than they circumcise their sons, well, it's easier to imagine them as human rights abusers because they are the proverbial other to Western policymakers. Now, with regarding the comparison about the invasiveness of the surgery, a forthcoming paper by Richard Schwader makes the following claim. Among some Muslim groups, and as I understand this is true in Malaysia, there's a gender-inclusive version of the Jewish Abrahamic covenant. Not only the boys, but also the girls are circumcised. In the Jewish custom, girls are excluded from what's considered the main rite of the religion. So on some view, by having both boys and girls circumcised, there's a form of equality. The procedure for girls amounts to a nick, abrasion, piercing, or small cut restricted to the female foreskin or prepuce. The custom is less invasive than a typical male circumcision, as routinely and legally performed by Jews and Muslims within the very same families. And Rick Schwader asks, if the practice is legal for the gander, why should it be banned for the goose? So this is an increasing move that's happening now among defenders of ritual male circumcision. They're arguing that since Western law and policy tolerates our cultural practice for the sake of equity, so too should we tolerate female circumcision as long as it's less invasive than ritual male circumcision. My colleagues and I have argued against this view. We tend to argue that there should be a concern for the child to be able to make their own decision. But anyway, this is an argument that's gaining traction. So this sort of situation was recently tested in the United States concerning this woman, Jumana Nagarwala, who's a member of the Dawoodi Bohra. The Dawoodi Bohra are primarily based in India and Pakistan. And according to the trade routes that were shown earlier, they practice a version of type 1, so there may be some partial cutting or removal of the clitoral hood. In some accounts, they practice a pricking like what's done in Malaysia. There's an immigrant community in Detroit, Michigan. The alleged cutting was done by a doctor in a clinical setting. The Bohra practice khatna, an Arabic word for circumcision that's a gender-neutral term, so they circumcise both boys and girls for religious reasons. And the typical male operation in this group is more invasive than the typical female operation, but only the female operation was regarded as criminal. So what happened? In 2018, this judge, a federal judge, Bernard Friedman, ruled that the US anti-FGM law was unconstitutional and it was struck down. Now, a replacement law has just been passed and we can talk about that. But the argument he made was very interesting. Why is the anti-FGM law unconstitutional according to this judge? Well, he said, we have a federalist organization in the United States where the National Congress is not allowed to pass laws that apply to all 50 states unless it meets certain specific requirements, like the practice affects interstate commerce or something like that. And so he said, actually, the pricking that's done by the Dawoodi Bohra constitutes local criminal activity, which means the states have to be able to legislate it, not the national government. So that's why the law was struck down. But what's the local criminal activity he had in mind? He said, this pricking, if it's medically unnecessary and non-consensual, just is a physical assault. And a physical assault is already illegal in all 50 states. So this creates an interesting situation. He's avoided confronting the issue of sex or gender at the federal level, but he's passed it down to the states, because if ritual nicking that's medically unnecessary is a physical assault, then doing a more invasive procedure to boys that's medically unnecessary is presumably also physical assault. Nevertheless, he's aware of the equal protection problem. He said, as laudable as the prohibition of a particular type of abuse of girls may be, it does not logically further the goal of protecting children on a non-discriminatory basis. So let me just sort of review what I've been talking about, and then I'll move to the final slides here. The first thing is that the WHO definition of FGM is scientifically meaningless, it's conceptually inadequate, and it's incoherent. There's no view on which this is a sensible definition of the word mutilation. Western law and policy on FGM is culturally biased and hypocritical. It selectively targets only non-Western associated forms of female-only genital cutting, regardless of the actual level of harm or the capacity of the person to consent. And it fails to condemn objectively comparable procedures that are more familiar to Western culture, like ritual male circumcision or cosmetic labiaplasty, as it might be performed on increasingly young girls, as I said earlier. So scholars who work on in this area use the term genital cutting now for females, males, and children with intersex traits who may be male or female or identify as intersex. The idea here is that culturally relative or biased value judgments shouldn't be baked into the very meaning of supposedly scientific terms. Rick Schrader, who I mentioned earlier, has said, imagine you're having a debate about the moral permissibility of abortion, and you ask somebody, what's your position on baby murder? Well, like it was just said, obviously that would be offensive to the view of the other person who doesn't view it as baby murder. In other words, you're defining out of existence the very point of contention. And so this leaves no room to have an honest conversation about the different attributes of different forms of genital cutting. It leaves no room to have an honest conversation about what is morally at stake in these different forms of cutting and why they're valuable to certain cultures and why they're seen as foreign to other cultures. So you can't just define practices in an offensive way and expect to have an adult conversation with your interlocutor. So what's a more ethically coherent position than the one that has been jerry-rigged by the World Health Organization? Well, I think to start to have this conversation in an honest way, you have to begin by acknowledging that cultural or religious body modifications of children are virtually always undertaken with the belief that they enhance the child's body, not that they cause net harm to the child, in line with locally prevailing social, aesthetic, medical, spiritual, symbolic, or other norms. So no loving parent is trying to mutilate their child, and to go into a conversation accusing somebody else of essentially being a barbarian is not a respectful way to start. I want to say something about this. I mentioned this at the World Health Organization meeting a couple of years ago, and the World Health Organization official said, well, when we're talking to the communities, obviously we use whatever language they're comfortable with, but we know that it should be called mutilation. And I just thought that was incredibly condescending and even more offensive. Decide what the term should be used and use it with everybody equally, and don't build your value judgments into the term. Okay, now here's the problem. If the parents or community believes that they are enhancing the child's body by altering it or exposing it to a certain kind of a risk to draw a drop of blood, their view that it's an enhancement isn't something that's necessarily universally shared, and it's the sort of thing that somebody could draw a different conclusion about if they have a different set of beliefs or values. So the very status of these culturally motivated genital modifications as enhancements versus diminishments or even mutilations is unstable and context dependent. Beliefs and values can change with new information or a new context or a new perspective. So I'll just give an example. A friend of mine was raised in a very conservative religious community and was circumcised for religious reasons, but he grew up to become a secular person, and he doesn't believe in God, and he doesn't adopt these particular views. And he says that every time he uses the toilet or takes a shower or has a sexual experience, he sees a scar on his genitals, which makes him feel that he's been marked with a sign of his parents' religious beliefs that he doesn't share. So obviously, if you share your parents' religious beliefs, you might think of this very same bodily state as being a sign of something very important, a covenant with God. But if you don't believe in God, then you just have a scar on your penis. So the idea is that this act, when you do it to a child, you don't know how they're going to evaluate it later in life. You don't even know if they're going to think it was reasonable for you to take a prick to their genitals to draw a drop of blood. This seems like a sensitive part of the body where you might rationally think that no sharp object should be taken anywhere that's part of your body. Here's some further examples. This is from the Dawoodi Bohra community that I mentioned earlier. As the years rolled by, I attained puberty, and after experiencing my first menstruation, I became aware of my sexuality. At this point of time, my second eldest sister gave me a book to read on sexuality. The full impact and realization then of that awful, painful, and life-changing procedure which I was made to undergo at the innocent age of 7 years dawned on me. I was privately distraught and enraged to learn that I had been robbed of my full feminine rights to sensuality and sexuality. This feeling disturbs and traumatizes me, and feelings of inadequacy and incompleteness remain with me till today, even at the age of 61. After making a private self-examination, I found that the prepuce or foreskin of my clitoris had been cut off. Here's an example told to Ron Goldman. The shock and surprise of my life came when I was in junior high school. I was in the showers after the gym. I wondered what was wrong with those penises that looked different from mine. I soon realized that I had a part of me removed. I felt incomplete and very frustrated when I realized that I could never be like I was when I was born, intact. That frustration is with me to this day. Throughout my life, I have regretted my circumcision. Daily, I wish I were whole. Now, I've read in some depth the testimonial literature for females who've come to feel resentful about their early genital cutting experiences, males who come to resent their genital cutting experiences, and also those with ambiguous genitalia or intersex traits. And often you don't see that there's any mention of complications. The person doesn't say, well, the surgery was botched. Rather, it's that they have a change of mind or perspective when they come into an awareness as an adult about what happened to them when they were a child. And a common theme, regardless of the sex or the gender of the person, is that it's the sheer involuntary loss of healthy sexual tissue, or the loss of genital intactness, or the loss of choice about something that might be seen as a very personal decision. That's what's often felt as a harm or as a form of disrespect. So what should we think about these cases? My colleagues and I have proposed the following ethical argument. While adults are in a position to decide whether effect or risk X is valuable enough to justify incurring loss Y, so if they think that the enhancement or the social benefits or the religious significance is valuable enough to justify the risk that something might go wrong with a slip of the needle, children don't have the capacity or the life experience to make those kinds of trade-off decisions. They don't know what they will value when they grow up, and nor do their parents, especially in a global multicultural world where people move to different parts of the world or interact with people with different points of view. So while an intervention that improves X may count as an enhancement for the individual who doesn't care much about Y, another person valuing Y over X will view the very same outcome as an impairment. In these kinds of cases, that is, cases in which the very status of an intervention being an overall enhancement versus impairment is controversial, the weight of considerations should shift toward delaying the intervention until the person who will be affected by it or have to live with the consequences is able to decide for themselves. Now, again, I think medical necessity is an exception here, and I want to explain why. Almost everybody puts a very high value on not dying prematurely or on preserving core bodily functions, alleviating relatively direct threats to their well-being that are recognized as such robustly across culture, time, and circumstance. Imagine that you're considering whether to do an open heart surgery on a non-autonomous person, maybe somebody who's passed out on their way to the hospital or a very young child, so you can't get their consent. Well, you wouldn't hesitate to perform the surgery, even though it's radically invasive, exposes the child to a lot of risk, and involves opening up their chest cavity, because you're very very justified in thinking that they would consent if they were autonomous. And moreover, you can think that regardless of their cultural background or beliefs, and despite any potential changes in perspective. You may not be able to have 100% confidence, but you can have about as much confidence as you could ask for, that this is something the person would consent to, regardless of the religious beliefs they eventually come to hold, regardless of the metaphysical views they might adopt. You have to compare this to the local epistemologies that justify culturally motivated genital cutting, where that you don't have the same guarantee. These are metaphysical beliefs that are not universally shared, that you might abandon when you grow up. They might be based in contingent or unstable aesthetic norms that apply to one cultural group but not to another. And so people can travel to a different country with different practices, or read a critical article about the practice that was done to them when they were a child on the internet. They might leave their community that they were raised in, and then they can have a change of mind, and they can come to see that what happened to them was something they prefer didn't happen to them. So I think in the future of law and policy, there's going to be a shift away from the x-axis here, which is determining whether a child has stereotypically masculinized or feminized genitalia or something in between as the basis upon which you should decide whether they're protected from genital cutting, to the y-axis, which is a question of how much autonomy does the person have? Is the person able to decide that having a sharp object taken to this sensitive part of their body is a risk that they're willing to tolerate because they themselves value the trade-off in the full light of their adult thinking? So these same colleagues I mentioned before, there are representatives from pretty much every continent and across many disciplines. We recently argued that cutting any person's genitals without their own informed consent should be seen as a violation of their right to bodily integrity. And so we argue that it's morally impermissible to cut a person's genitals unless they're non-autonomous, so they can't consent, and the cutting is medically necessary. Now, there are a lot of open questions here, even if you find that argument persuasive. There was the question of how would you change WHO policy to remove the existing cultural and moral double standards? Should we be thinking about legal changes being applied here, or is it just a matter of consciousness raising and advocacy and education? Many other open questions, but because I've gone on for half an hour, I'll go ahead and end there. And thank you for your attention.
Thank you, Brian, for your presentation. Now we have some time for questions. So we have one question for Dato by Dr. Diana Rafiq. Was there a fatwa made by Islamic scholars in Malaysia in 2009 banning or condemning the practice of FGC? I think you're on mute.
Am I?
Dato.
Yeah, can you hear me?
Yep.
Okay, so there was a fatwa in 2009, I think. It was made by the JAKIM, which is the organization responsible for Islamic practices in the country. And they said that female genital cutting is actually wajib, mandatory. So it should be done by all practicing Muslims of the Sunni sect who follow the Shafi'i school of jurisprudence. However, fatwa is non-binding. There's also fatwa against smoking, which smoking is considered haram, which means that you shouldn't be smoking, but nobody gets arrested for that. So it is non-binding. Fatwa in this country is actually religion is under the state. It comes under the jurisdiction of the states rather than the country. So in some states, for example, the state in East Malaysia, Kelantan, it is wajib. That means it's mandatory. But again, there's no one there to enforce it. Whereas in other states, it is not mentioned. It's just silent about it. No one says that it is haram, though. Which means that you shouldn't be practicing it. Again, I'd like to remind you, fatwas are non-binding. And the comparison you can make is to smoking, because smoking is considered haram, and there's a fatwa. Almost every state in JAKIM has come out with it. But if you go for prayers in the mosque, you find that everybody is smoking there. So I hope that answers the question.
And a question on circumcision by proxy. So, Prof, Dato, you mentioned that there's a tribe in Indonesia which practice circumcision by proxy. So I've spoken to some people from a certain NGO, and they would still consider it as FGC, and we shouldn't be doing it at all, even by proxy. What are your thoughts on that?
Well, this is very interesting. You see, this whole thing about, I love this NGOs. They're really very good. I do a lot of work with NGOs themselves, but sometimes you just carry it a bit too much to an extreme. So it's an evolution, as I said. The whole idea was propagating Islam. It's just like, circumcision, male circumcision was mandatory during the time of Jesus, and then after that, when Paul wanted to introduce and people were reluctant, and circumcision went off. The same thing applies here. So as I said, from type 3 to type 1 in India, and then you have type 4, And then when you went to Indonesia, Java, and some parts of Java, people were like, no, I'm not going to do that. So to get people to do it, so they had thing called this by proxy. They put a tuber and then they cut the tuber. Now you tell me, how in any stretch of your imagination can you even call that a mutilation or circumcision or cut or surgery or anything? You know, the only damage you're doing is to the tuber. It's got nothing to do with the person itself. Recently, I'll just give you a story that I think, Hannah, you were present in one of the talks on, I think it was to the United Nations bodies or something. And there was this presenter who did a research from Bangsamoro, that is south of Philippines, where now they claim they practice female genital. She kept using the term mutilation until one part of it. What they do is actually they take a piece of cloth and they rub it against the child's vagina. No harm, there is not even a drop of blood. They just rub it and that's it. They consider that as, so again, this whole evolution of this female genital cutting. And she kept using the term until she stopped one part of it and she said, I don't know what else to call it, so I have to call it female genital mutilation. Now, rubbing a child's, vagina with a cloth and you're calling it mutilation. Even she felt so silly, but the problem is this terminology has pushed her to a corner that she feels that what else can I say? What else should I use in this discussion? So this is the problem. You see, where do you stop? What about if the parents say, fine, we're not going to even do it by proxy, but what I'm going to do is the whole family going to gather around and we're going to really imagine very hard that a cut is being done on the vagina. Then is that mutilation as well? Where does it end? It just becomes one extreme says that stop it completely, you guys are barbarians, and the other extreme says that you have to do it, otherwise you are not a follower of our religion. So we need to take an informed decision. You might agree, might not agree, but it has to be an informed decision. And this is where we lack. We don't have proper discussions on both sides of it. And unfortunately, some NGOs get a bit too excited. I'm talking both sides, don't get me wrong. Now I get another phone calls and abusing me. But it's just that, the Muslim NGOs get very angry and say, this is our religion, do not get involved in it. And this, well, it's my religion as well, so I'm getting involved in it. So don't get involved in it, we know what's good for us. And then you have the other end says that, no, this is bad, and you don't know what's good for you, and we know what's good for you. So the informed consent, informed decision, I think, is extremely important, and that is something we completely lack.
Okay, so another question here. Not calling female circumcision as type 4 FGM is making light of the abuse. So all of us agree that this practice must stop. I agree this practice must stop. Dato agrees that this practice must stop, and clearly Brian disagrees any form of genital cutting on babies who can't do any informed consent. So are we making light of this situation by not calling it mutilation?
Well, one thing that we should keep distinct is what we call something and what our attitude is toward it. So obviously, part of what's contested between different communities is what we should think about female circumcision. Those who endorse the practice obviously think of it as a positive thing. They don't think of it as abuse. Those who object to the practice think that it's wrongful, but they're often confused about why they think it's wrongful. Sometimes they'll say, well, it's wrong because it's very harmful. And it's like, well, not really. It's not any more harmful than other things you don't object to. So then they say, oh, well, it's wrong because it symbolically expresses an attitude that we don't like. And it's like, oh, do you get to decide what the appropriate attitude is that every family expresses toward their children, regardless of what harms are at stake? And then they might retreat to something else. And in fact, the symbolic meanings that are associated with female and male genital cutting in different cultures are wildly different depending on the group. Some people have argued that what you should be concerned about is a group that only thinks that boys deserve to have their genitals cut and that exclude girls from genital cutting, because obviously from the point of view of the community, genital cutting is positive. Again, we have to get out of our minds the idea that parents are trying to mutilate or abuse their children or humiliate them or denigrate them. You might think they're mistaken. You might think that their social ontology is confused, but obviously from the parent's perspective, they think of the cutting as an act of love, as something that's going to help integrate their child into the community. And so if from their perspective it's a good thing, you should be concerned if girls are excluded from the ritual, not if they're not included in the ritual. So the symbolic meanings argument is based on stereotypes from the 1970s, where somebody decided that FGC is all about subordinating female sexuality. But the anthropological record doesn't support that as a universal interpretation of what the symbolic attitudes are. So I think nobody can deny that what's involved is cutting or pricking, and so genital cutting is an accurate term. But then what do you think about the cutting? Then you have to have a moral argument. But you can't define your moral conclusion into the word and then force it on the very group of people who disagree with you morally. That's no way to have a serious conversation, and it's completely disrespectful of the communities that actually value these practices. It basically says, we don't give a damn what you think about these practices. We've decided that they're morally impermissible, and in fact, we're going to define them as morally impermissible, regardless of the level of harm involved. And that's just not a serious way to have a conversation.
Absolutely. And Prof, do you have any opinions on that as well? Do you want to add anything?
I completely agree with this. As I keep saying earlier, it should be informed. People should know what they're doing and then let them decide. You'll be surprised at how things change. There's a community in Sarawak in East Malaysia that practice. They should elongate they used to, children's head, they would, well, if you use the word crush, slowly so that the head doesn't become big. And that practice is, I only came to know about the practice one day. I was walking in the museum in Sarawak, and I said, wow, that's amazing, they do that. And then you find people in north of Thailand where they elongate the neck. And that practice is slowly going off. When I was a child in Malaysia, I remember the Chinese women would walk around with very small feet. They used to bind the feet because that was the beauty. And now you don't find that at all. Even if I tell that to my students, they go, did that ever exist in Malaysia? I say, yeah, it was a Chinese practice. Simple things which I tell people is, in Malaysia, people used to spit because it's a common practice. So when I was young, we would see spittoons and people would spit in it. So you'll find in restaurants spittoons, and you don't find that now. Now, if you would spit, everybody would go, what? You crazy? Who spits? But it was a common practice. I'm not that old, but we're talking about what, 30 years ago, 35 years ago. Spittoons were so common, and now even Hannah is going, what, really? Things, but it was there. You make people understand. Have some respect for people's logic. Make people understand, and they will come up with the right decision. The problem is we're not. We're insulting people. We're deciding for people. Both ways. Again, I'm not saying only one side. I'm saying both ways. We're deciding for people what is right and what is wrong without giving them enough information. We talk about informed consent in medicine, but why not informed judgment for parents? How to it's just like breastfeeding. I mean, every child used to be fed on formula milk, and now mothers, even from villages which I go to, they know that breast milk is the best. So they stopped, buying all these formulas, and they realized that this is the best thing for my child. How do they know that? It's because the information that we give. So they need to be informed. And what I'm saying is, it's going to take some time. Be realistic. I know there are people out there, NGOs, going to get angry and say, ban it now. What? To what extent you ban it, and then what? It's going to go away? It's not going to go away. People are still going to practice it.
Yeah, and I think you also have to ask yourself, who has moral standing to tell another group what to do or not to do? Let's say that we just accept the term mutilation for any medically unnecessary genital cutting done for religious reasons. Well, if somebody from the United States that practices some form of genital cutting that they think is okay, and then they go to another group and they don't like their form of genital cutting, and so they call that form mutilation, but they don't call what they do mutilation, then it's just an inconsistency. So I think, well, you don't have any moral standing to tell some other group not to cut their children's genitals for medically unnecessary reasons because you do that. And they go, well, they do it in a way that we don't do it. Well, of course, but that goes back to Herodotus talking about how cultures, everybody thinks that the other culture's practice is barbaric, but surely we should be aware of that kind of bias and ask ourselves, if we're going to criticize another culture's practice, on what grounds are we criticizing it? And we need to be very precise about that. Because if we think we have some insight into human rights that these poor barbarians in this other country don't know about, we better be confident that we've done our moral philosophy correct. And we know precisely the principle that we think that they're guilty of violating. And then whatever that principle is, we should first apply it to our own culture and see whether we have any practices that perhaps fall short of that principle. And if we do, we should first get rid of all those practices, and then maybe we can take the moral high ground and go marching around and tell other people what they should do in their cultures. But the groups that are, busy criticizing do not apply the same moral standard to their own cultural practices. So they have no moral standing to criticize what's being done in another culture.
And we have a comment from Rosanna Issa from the Sisters in Islam, sorry. The legal reasonings by the Islamist jurists is something that we should study as well. There have been legal reasonings given in the mazhabs of Hanafi, Maliki, and Hanbali that female circumcision is for the pleasure of men, and by the Shafi'i to reduce the libido of girl or women. Most Muslims do not interrogate these legal reasonings, which is based on the understanding of the jurists of the past.
Can I comment on that? They say the problem is when you read something that is claimed to be said by this jurists, there's a lot of you must understand this was something that was compiled over 200 years after the death of the Prophet. So even they admitted that that is why they have got three standards. Authenticity is good and is weak. So the ones that you're saying that what they claim it is actually weak. And I've spoken to, of course, I'm not a religious expert at all, and I speak to religious experts and I ask them their honest opinions, and they tell me that, well, it is weak. That's the whole problem. You see, that is why we have so much controversy in Islam concerning this practice. If you go to Egypt and you look at all the experts in Al-Azhar and the Mufti of Egypt, and he said, no, stop it. And I've spoken to the Muftis here who said that no, it is not compulsory, and the other one says that it should be stopped completely. So you have people in the community which is believing something else, and then you have those religious experts which believe completely something else. So that message is not coming down. So the information is not getting there. And then you have another group of people who read something without first understanding what is the source of it. Whatever you read, you may give references to books and papers and articles, but it's only as good as how good that article is, how reliable that article or that paper is. So you're reading something which is claimed that this jurist said this, but understand, is there an authenticity, or is it something based on what they assume that what the jurist was saying? So this is something else that I know it's a bit more related to religion, but I think that needs to be clarified, because it's not fair to blame them completely as well, because sometimes things are said that an opinion piece is given that this is probably, except the word probably, it gets removed, this is what that person said. But is that true, what that person said? Go, authenticate what information that you're getting.
Can I add just one point about this? Because this concerns the reason for which a practice is done. So one common claim is that female circumcision, depending on the culture, is either to suppress female sexuality or to enhance the male sexual experience, with the idea that there's an asymmetrical expectation. Women should not enjoy sex, but men should. And one thing that might be worth asking here is, if we assume that it's worth criticizing asymmetrical sexual standards for men and women, which is my own view, we have to ask about the relationship between that standard and the presence or absence of genital cutting in a given community. So most societies around the world could be described as patriarchal, but most don't cut the genitals of girls. And there are some cultures that are highly patriarchal and have highly asymmetrical sexual standards that don't engage in genital cutting of girls or boys, or they may cut the genitals just of boys. So there's no consistent relationship between the degree of sexual asymmetry in terms of norms for males and females and whether a culture practices male or female genital cutting. So you have to then ask yourself the following question. Suppose that you go to the family and you say, well, the reason why this is especially grievously wrong is because it's for the purpose of diminishing female sexual pleasure. So then what if they come back to you and they say, well, no, we're not doing it for that reason. We're doing it for because it's religious, or we're doing it because it's healthy, or we're doing it because it's tradition in our culture. Is your view going to change? Are you going to say, oh, well, in that case, it's fine, go ahead? Well, if your view wouldn't change, then you can't assume that the reason why this practice, compared to all other practices that happen in cultures, is the one that should be the topic of an international human rights campaign. Because every culture has many different ways of affecting and controlling the sexuality of boys and girls in different ways. And so, you know, as long as you have an equal campaign for all the different ways that cultures are concerned about childhood sexuality, you have to ask yourself, what is our obsession about this particular practice? And I think part of the reason is that it goes back to, you know, colonialist attitudes toward practices that are seen as surprising and striking and different from what we do. And so we focus all our attention on those practices when, you know, there's a myriad practices that have similar symbolic meanings that we don't seem to be very concerned about.
Yeah, I just want to clarify as well, like Sisters in Islam is definitely against FGC. It's just that I think that when we want to engage people in the community, I think we also have to acknowledge that certain conclusions made by Islamic jurists, not that we are disagreeing that it should be done, if that makes sense. So would you say that if a child grows up wanting circumcision, should we stop this person, or should we agree that this person can have the circumcision? I'm talking about people who have converted and becoming Muslims when they're an adult, and they go and visit their doctor and they say, I want to have this done because I believe this is what should be done to me.
I'll say a word about this and then defer to the professor. But if you're in the United Kingdom and you're, say, a middle-class white family, and your daughter turns 18 or even 16 or 17, and she decides she wants to have a large proportion of genital tissue removed for trivial reasons, like she thinks it looks better, at least when she's 18, she'll be allowed to do so. But if you come along from a Muslim religious family and you say, I'd like you to remove less tissue, say part of my clitoral hood, for what I take to be metaphysically very weighty reasons, I think this actually helps me be a good religious person. In the very same country, you'll be forbidden from doing so as long as the doctor characterizes what you're doing as a female circumcision. So again, we have to decide what our reasoning is. My view is, if you're an adult, it should be up to you what you do with your body. And we don't have to inquire into your reasons, and we don't have to judge your reasons, and who are we anyway? Do we have all the right answers about what the correct reasons are for pursuing bodily modification? If you're an adult, and generally speaking, you're allowed to pursue surgery, and you're going to pay for it, it should be up to you. But what's happening now in the United Kingdom and also in Australia is that whether a person is allowed as an adult to pursue a medically unnecessary genital surgery is adjudicated on the basis of their perceived racial or religious group membership. And so a surgery that's even more invasive, that's done for what are reasons that are accepted by Western culture, namely cosmetic reasons, which you might think should not be given much weight, are allowed. Whereas if somebody comes along and says, I want a female circumcision that's less invasive than what you just allowed that white girl to do, they'll say, no, we can't do it. It's illegal. That's FGM in our country, because the UK and Australia don't even have an age distinction. They say that even adult women are not allowed to pursue FGM, which they simply define on racial grounds. So in the US, it's a bit different. If you're 18, you can sort of do whatever you want. And I think that that's actually basically the right view. It's not up to the person to interrogate your reasons and condescend to you that they know better than you why you're modifying your body.
Thank you, Brian. And Prof, what's your opinion on that?
Well, I have come across some adult Muslims who convert into Islam and they get married, and then, you know, they are told that you have to do this, you know, otherwise you'll have a problem. You'll not be a Muslim. So they reluctantly go and do this. But this is where, again, you know, the information that they're getting, we're coming back to the information again. You see, the information that they're getting, are they getting the true information? Are they getting the whole, you know, picture of what information that you're giving? Are they making informed decision? Which they are not, because the information that they're getting is only, you know, one view of it. So in my aspects of it is that, you know, it should be clarity, and this is where the religious department, who a lot of them say that it is not mandatory. They should have, full information given to the person that you do have a choice whether you want to or not. And I agree with Brian. Once you're an adult, it's your body. It's up to you. What do you want to do? Put tattoos or whatever, or cut what and do what. It's up to you.
Okay. I think.
May I say one just quick thing about this? I think there's one further consideration here, which is the stereotyped view is that if you're coming from an immigrant community and you want to do something for cultural reasons, the view is that you must be brainwashed in your culture. Now, there's something to the view that it may not be a free choice, as the professor was just saying, in that you may not be fully informed. You might feel pressured into doing it. But then it's often thought that Western women are just making free choices, like they're these free agents walking around. Well, Western women are obviously influenced by their culture too. They're made to feel that their vulvas are ugly because the cosmetic surgeons can earn money by causing them to feel ashamed of their bodies. So it's not that they're just making some totally free choice. We're all influenced by our cultural upbringing. We all make decisions under constraints. And so again, whatever our view is about whether an adult should be allowed to modify their body, I just insist that it be done equally, that each person be given the same reason and not a separate story depending on what group they come from.
Okay, just to close things up, what do you think that we should do to stop this practice in the Malaysian context? What do you think we should do, Prof?
It's going to take time. It's going to take a lot of time. Be realistic about it. It's going to take time. Well, the first thing which I'm completely against is medical doctors practicing it. Why? Simply because what are they following? What are they cutting? There is no guidelines. There's no, we don't learn that in school, medical school. If male circumcision, we do learn it. We know how to practice. We are taught how to do. So you get people who are pricking, some who are cutting, some who are cutting now. The clitoris is based on what logic they think it is. And logic is just based on the amount of information or knowledge that you have. So this is what I'm against. And I think the Malaysian Medical Council should come out straightforward and say that, this is something that you don't know anything about. So stop doing it, But it's going to take a long time. Be realistic. It's going to take 10 to 20 years. And I say don't ban the practice. Nothing good is going to come out of it. What's going to happen is they're going to go underground and then things are going to get worse. They're going to use equipments which are non-sterile. People are going to get, children are going to get infected. And, it has to take time, and people should come out and speak and have open discussions about it, and let the parents know what it is. And I strongly believe a very large portion of them, you give them a choice and give them enough information. As Brian said earlier, the parents, whatever that they're doing is for the benefit of the children. Everybody wants the best for your child. And if they know and they have a choice of what is best for their child, I'm sure they'll make the right decision. So before jumping and banning things and stopping, well, at least in the Malaysian context, I think that first thing is discussions need to come up with, and give enough information to people. When people read this information, they will know more, they'll make better choices. And that's going to take time. You just can't stop a practice overnight. It's going to, something that's been practicing for hundreds of years, give it a few years before, you start seeing changes. But one thing that's good thing in Indonesia has is they have the national data, which we don't have. That's another thing which is very helpful, which we should have, is, this Ministry of Health and all the others, let's not discuss about it. Don't talk about it. It doesn't exist. So this idea, they should stop. The discussion should be there, open discussions, respectful discussions should be there. And I think that is the best way to go for the moment.
Okay, there's a question from Lizana Latif. She's a counselor based in the UK. Has there been any research carried out in Malaysia to learn more about long-term of psychological effects and mental well-being of women undergoing FGM in Malaysia?
There's only been one study that was done in Kelantan many years ago, I think early 90s, if I'm not mistaken. And it wasn't done on psychological, it was just done on the anatomy And what they found was they couldn't find anything, and the patients actually said that, yeah, we went through the procedure, there was no scarring, there was nothing at all. And that's the same thing which we found when we asked them, do you have any side effects? Do you see that your vagina is any different, or you see any scarring or anything? And we get the same thing because it was such a minimal procedure, very unlikely. I know people talk about, oh, there might be a development of keloid, but then keloid can develop anyway. You can get a vaccine and keloids develop, so that's exception, that how your body reacts. But in general, no, because the practice was minimal. However, it would be interesting to know about, mental health. Once they come to know about it, what do they feel about it? And those who have undergone practices where type 1, where part of the clitoris is cut. So we don't have that. What we have is what was done by the bidans, by the traditional midwives, which was just a small prick, and that's it. So we don't have actual data that suggests any serious physical effects. Mental, no studies have been done on that.
Both of you have made very good arguments, but like how the communities in Malaysia, they rely on fatwas, and they believe if it's a religious obligation, they will do it. Do you think that the Ministry of Health should consult the JAKIM or any of religious bodies in Malaysia to stop this practice?
They did consult, and the religious body said continue with the practice.
Mm.
You see, the problem is the same reason we don't trust politicians is we don't trust people in power. And JAKIM said that smoking is haram, don't smoke. Nobody stopped smoking. So people in power, people don't listen. They, unfortunately, a lot of what people believe in is what comes out in your WhatsApp and your Facebook and stuff. So there should be more discussions on the social media, because people really don't believe. Nobody takes any heed of what the religious council says, or what the mufti says, or what the government says, or especially look at now vaccines in Malaysia. We're having so much problem. People refuse to get vaccinated because people don't believe what the ministry is telling you. Listen, it's very safe, it's good for you. We have all the evidence there. And then one clown comes up and puts up in WhatsApp, see people getting vaccine and dying. And everybody starts forwarding the one that this person is dying, and nobody forwards the truth. You see? So relying on what the minister or ministry or what the authorities are going to say is ridiculous. We should be more proactive and give more information on the social media, because unfortunately that's what people believe. People think if it is out there, it must be true.
So I have another comment. JAKIM is open to reviewing, but so far in the Sisters in Islam's engagement with them, they don't have a good perspective of what it means by harm, because as you can see, if type 4, there's no visible harm. And basically, JAKIM stated that as long as the person has not died and there's no harm, and regardless of any complications that happen, which is about 50% of those studied by Professor Masna Daloy, they are not going to say that we're going to stop it. So, which is why I think we should move away from this medical complications thing, because type 4, there's no medical complications. I think it goes back to respecting genital autonomy of children, because they have the right of their own body as well. One last question, and
one quick comment. The problem with JAKIM is that they feel comfortable in selecting which academic they want to talk to. You get what I'm saying? So if their idea is this, and any academic which agrees with their idea, that's the discussion they have with. I think I do a lot more than anyone else in Malaysia on this. I've never been invited, never been called, never received, no one has ever discussed with me on this. You know why? Because my idea doesn't, gel with what their thoughts are. So what the ministry or JAKIM or whatever decide is, just ignore it. That's all I can say. Sorry, Hannah. Yeah.
But of course, people rely on JAKIM for their decision for their children, for example. So say if you're a doctor in an office and this person comes in and say, oh, I would like to have female circumcision done to my child. And many doctors I speak to say like they either pretend to do it or just a prick, so as a harm reduction thing. What are your thoughts about that? I'll ask Mr. Brian first.
Well, yeah, that's very interesting. The question of harm reduction is curious because there's a distinction to be drawn between whether something is harmful and whether it's wrongful or disrespectful. So something can be harmful without disrespecting the person. So for example, if I accidentally bump into you and knock you over and you scrape your knee, I will have harmed you, but I didn't cause you any disrespect because I didn't intrude on a decision you should have been able to make for yourself. But I can also wrong you without necessarily harming you. So if you're asleep and I fondle your genitals without your permission, I maybe didn't harm you, but I've disrespected you because I've taken a decision that you didn't give me permission to take that should have been your decision. And so I think the problem with a lot of the discourse is that most people conflate these two things, including the World Health Organization, including a lot of doctors. They think to themselves, well, if it's not harmful, it can't be wrong. And that doesn't follow. Something may not be physically harmful in the sense of there's some measurable functional outcome, but it may still be a matter of disrespect to the person. And that's sort of the view that I take. And then on the matter of psychological harm, just quickly, those studies are almost impossible to run because the psychological effects of a potentially traumatizing event, like an early active child genital cutting, depend on so many variables, including the individual's resilience, their attitude or perspective toward the cutting. So if you see it as bringing you closer to God, you're probably not going to be traumatized. If you see it as your parents are marking you on your genitals with the sign of their religious beliefs, you might be extremely traumatized. And that's actually independent of the degree of severity of the cutting. And so the ceremonial context, the age at which it happens, individual attributes of the child as to whether they're inclined to be empathic towards the suffering of others. Those sorts of individual attributes vary considerably. And so you won't ever be able to make a sort of unilateral statement about how it affects psychological health, because that will always be highly variable.
Okay, so say you would say no to this particular patient, and this person.
I'm realizing I didn't really answer your question. Sorry. Yeah, I think that doctors have an obligation to speak truthfully. They have a fiduciary obligation to be honest with their patients. And so some colleagues and I are arguing that also in the Western context that medical professionals have to be able to decline these requests. They have to say, it's not medically justified for me to do this, and I can't take orders from you to perform unnecessary procedures on your child. That's not how medicine works. I have to give clinical judgment, and you might say my professional medical society forbids me from doing this. So I think it would actually be, rather than jumping to criminal bans, for example, I think the professor's right that getting doctors to have a unified front and have some backing from their professional associations so that they can simply and calmly inform parents that they are not professionally allowed to do it. It conflicts with their professional duties. Yeah,
that's really interesting. I mean, obviously, like when it comes to abortion and many other things as well, if a certain practice conflicts with the personal beliefs of the doctors, they will not do it. And I think on this basis as well, like it's not a medical procedure and doctors shouldn't be doing it. However, there is this idea that once you decline this patient, this person might go to another doctor and the baby will have type 1 or type 4 FGM. So when I say harm reduction, some of these doctors actually pretend to do it. So do you think that is right or wrong? Because in the end, the child is unharmed.
Yeah, there's something called a slow code that doctors will sometimes do. It's not part of the official curriculum, but this is if they have a family who says, I want you to rescue grandpa no matter what. And the doctor thinks, I should not be performing CPR or chest compressions on this frail old man who's about to die. And in my own good conscience, I can't do it. So what they do is they tell the family, okay, I'm going to try to resuscitate your grandfather. And then they go over there and they sort of fake the compression because they don't want to just be breaking this person's ribs. They can't do it with their own conscience. And for these doctors, it causes them a lot of distress because they're lying to the family while trying to maintain their own sense of medical ethics. And so, it may be the case, there's some discussions about this, that there are some cases where you might think that's the best possible solution to an unfortunate problem. There are others who suggest that it's impermissible to lie to your patients. That's contrary to the doctor's fiduciary duties. And so you have to come up with another solution. But your point is it's a collective action problem. Any one doctor can't unilaterally decide to do something and solve the cultural problem, because then somebody just goes to another doctor who will do it. Similarly, you know, a given family can't just decide not to do a procedure for their child if all the other families are doing it and they think that the child will be disadvantaged in some way. And so that's why it has to be a public conversation. And it has to be one where everybody is sort of coordinating their behavior and you're pulling many different social levers, not just thinking that some one authority is going to solve the problem by, you know, passing a law or whatever it might be.
Thank you, Brian. And your thoughts on this, Dato?
From the study that we did, what we found out was those who practice are those who really believe that it should be done and they practice it on their own children. And those who don't think it is and they don't practice it. So it boils down to the same thing again. If you can get the medical council to say that, listen, you guys are not trained for this, so you shouldn't be practicing it. And that would resolve matters very easily. Harm reduction, yeah, a lot of excuse has been given that, you know, oh, if we don't do it, then they go back to the traditional midwives and God knows what they're going to be doing and so on and so forth. So there's a case there as well. You know, what do you do? Because as I said, some of those that we interviewed and some of the equipments that I saw, it's a bit scary because I did see some blood stains and I saw one rusted pen knife. So yeah, this is another thing that we need to have open discussion about. You know, what do we do? When do we do it? And you know, do we stop it? Or I don't know. This is what we lack in Malaysia. We don't discuss. Everything is just assumed that, you know, things are going, so just let it go as it is. And this is what we need. There's one thing where I got to compliment you, Hannah, on starting this group where we can have a lot of discussion. There are other discussions as well, you know, like postnatal practices, you know, traditional practices which are actually harmful. But again, you know, hopefully more and more discussions like this will come out and we'll have, you know, better judgment.
Okay, I think that's the last of all the questions. Thank you so much to both of our speakers. Thank you, Dato. Thank you, Mr. Brian Earp. I mean, it's late at night at your place and probably early morning at mine. So thank you so much, everyone. And we'll probably send a feedback form. Could you please answer truthfully whether this is useful or not? And hopefully we'll be also having a forum for doctors to talk about this practice and see a way forward. And the next webinar is going to be FGM in Europe as well as Africa, and we will inform you the date. Thank you so much, everyone.
Thanks for organizing this very much.
Thank you. Thank you.